We are going to record today's video so that you'll get a copy of that link afterwards. So if there's anything you want to go back and revisit, you'll be able to do that. Thank you to everyone brave enough to turn your cameras on today so that we can feel like we're talking to each other and not just to technology. My name is Stephanie Diaz with Humanly. Humanly provides professionally curated office space for private practice therapists and wellness professionals. We're really proud of the amazing group of professionals that we have in our offices that are working every day to help people live more fulfilling lives. And any chance we get to really highlight our members, we love to do that. And Brent is here today to talk about some things that he's really passionate about. And I just wanted to say thank you so much, Brent, for taking the time to be here, for being willing to share your knowledge. This is such a hot topic. I am personally very much looking forward to hearing what you have to say. I'll turn it over to you so you can do a little bit more of a thorough introduction. But thank you again. I really appreciate your time and the energy that you've put into putting together a great presentation today.
Great. Thank you for the introduction there, Stephanie, and for the opportunity to speak to people. And in a past life, but this current life, I was doing a lot of public speaking. So it's actually refreshing to get back in front of a few faces. It's very odd to be doing it in front of a computer, but thanks for putting on your videos just so I can actually see that there are other humans out there in this wild world. Just in case a few people arrive a few minutes after this, I was just curious, and Stephanie just posted in chat to feel free to post questions as we go. I tend to be more of a contextual teacher and learner, so I'd rather answer questions that relate to something I just talked about and not 30 minutes ago, or that I'm going to speak about in 30 minutes. So if you have any questions, please post them as they come up. And then just out of curiosity, if you're willing to type, I see all of your names, which is awesome, but if you're willing to just type why you're here, why are you curious about ketamine, if that relates to your professional life or if it's a personal interest. It can be very brief, but it helps me just orient to who's in the room. And if you want to share where you are in the world, that's cool too, because it's great to know if I might actually meet one of you one day if you're in the Denver area in Colorado. Just gonna skim through these. Lynn and Aurora. Okay. Okay. So a couple people in the area here. That's great. So I know there are events, whether they be online or sometimes in person. I've attended some events in Denver at the Mercury Cafe, for example, by the NOAC Society. But yeah, feel free if you're here today and you're at one of these events, you recognize me or vice versa. I love to build community when it's so difficult right now. So it's obvious I'm going to speak about ketamine today, and what I'm going to try to focus on a little bit are things that maybe you're not going to read about or hear about if you go to a training. And so some of it's my opinion or coming from colleagues, but I wasn't exactly sure who would show up. So I just tried to keep it somewhat broad, and we can always spend more time on a certain topic at the end if people are gravitating towards certain areas. Stephanie, I am going to keep the chat off my screen just so I don't get distracted. I am distractible. So if anything pops in, if you don't mind just interrupting and letting me know if we should take a question or pause for a second.
Absolutely. I'm on it.
Okay. let's see, is my, oh. All right, I can't use my arrows, so I'll have to click through these slides. So just a brief bio. I don't know if the bio was shared in the information. Did people get a chance to read my bio when you signed up for the thing? Was it there? Can I get a head shake or a thumbs up? No? Okay. All right, then I'll give just a brief bio. I didn't want to be redundant, but I went to Dartmouth Medical School and originally was in family medicine. Coming out of residency, I wasn't sure I ever wanted to see patients again. And it wasn't because of patients, it was just the system that didn't feel philosophically aligned with how I wanted to practice. And so I did kind of a side journey in clinical research that related to nutrition being taught in groups to diabetes patients. And then some nutrition writing. So medical students actually get to learn about nutrition. And then I was so intrigued by group models of care that I ended up doing consulting work in that area and a lot of public speaking to help people learn those models. So if you're coming from a mental health background, group therapy would be fairly common, at least in your knowledge. In the medical world, it's a lot less common, but there are group models of care where people can learn and have peer support and have a lot of the benefits that group therapy shows. And it was 7 years ago that I'd had a lot of ideas. I was kind of trying to generate and figure out how could I pull off something that supported me, but also supported patients. And I started an integrative holistic medical clinic. And that is one that takes insurance, despite all of the challenges of that. I think it's also what really helped me choose a different path when I started to learn more and more about psychedelic medicine. So a couple of years ago, I created another concept that was going to be more inclusive of other options for mental health besides what I was doing, was just essentially medical or medication management in primary care. So we started with neurofeedback and then ketamine. I did my ketamine training a year ago. And I've been doing various types of sound therapy, whether it's myself or my daughter, around sensory processing challenges for over a decade. So I'm quite intrigued by sound therapy modalities too. So the objectives, if you saw these, I just want you to know they did get refined slightly. So if there was a prior version that you really wanted to hear about, just remind me. But I tried to slim things down and not try and do too much in a short time. But I will talk about ketamine and also esketamine, and then talk a little. I love music. I love the idea of how we can use music to heal, and especially if we're crossing sound therapy with other therapies. I have a lot of passion in that area, so I'll bring that up. And then this is the area I just thought it might be interesting to explore, because I'm not going to be the expert in what the future holds in this really unpredictable world, but I do see some signs, just even in my own practice or talking to colleagues about maybe what's coming. So I'll just speculate around some hypotheses or even just ideas, and if people want to share their own vision or their own opinions of where things are headed, that could be a great conversation or something we do more in the future. So psychedelics, this is only a very short list. There are clearly many more, but I just wanted to do a quick summary that, we have archaeological representations that psilocybin mushrooms have been used probably for 12,000 years at least, but who knows? It could be double that or triple that or many, many other millennia. And then contrast that with synthetic versions of psychedelics. It's really been in the last 80 years that we've been, creating these, sometimes by accident. But LSD in 1943 was the first use, but actually created around 1938. And I'll talk about research in a second, but really profound research to show benefit in a major way. And that just, having missed this, being born in the 70s, I didn't see a lot of the illegalization of these meds, but to see such profound efficacy and effectiveness of these drugs, to know they got illegalized still just baffles me. And that's kind of my biggest challenge with our medical system, our allopathic medical system, and just how much politics can drive whether a drug is considered of benefit or not. So ketamine came out in 1964 as far as first use, and then MDMA, known as Molly, ecstasy, and other recreational circles in 1976. So just contrasting that to something we know has been being used for 12,000 years, I just find it interesting that we've just started to synthesize things in the last 80 years around that. So in the 50s and 60s, there was a lot of good, solid research. And one example is with LSD, that imagine just giving a single dose of LSD to an alcoholic and knowing that almost half of them would quit drinking in a year. I mean, that's a revolutionary type of medicine right there. But, why are we not using that? That's a huge question in my mind to this day. And I can come up with all sorts of reasons why we aren't, but it just baffles me that we're not always looking at this data from an altruistic frame of mind, unfortunately. And then other research, some of it high quality research, I think just got a little bit careless, reckless, cavalier, and it ultimately created a lot of stigma around these medicines. And thus we've had this illegality of so many of them since that time. But ketamine has continued to be legal throughout all of this, and primarily because its FDA approved use was for anesthesia, and a super safe anesthetic for older individuals, for children, for large animals. So I think at that level, it was hard to imagine, how do we lobby against anesthesiologists and veterinarians? So I imagine that's why ketamine sort of escaped some of this. All of the other use, and I did misspeak in one of my intros if you happen to read it, but anesthesia is the only FDA approved use. I originally said pain relief, and I think that just shows how some of the lore of the fact that we have a lot of infusion centers run by anesthesiologists or emergency medicine physicians, where people can go in and get this medicine very easily, and often it was for pain relief. So but as we get into mental health and so many different uses, they are all technically off-label for ketamine. And I'll contrast that with our newest studies on another version of esketamine. But DEA-wise, if it's a Schedule 1, that's considered to have no medical use, even if that's not necessarily true. So cannabis is still a Schedule 1. And then, so ketamine being Schedule 3, I just view it as, it has less likelihood of addiction, and it has clear medical benefit as we move further down the schedule, but it is still controlled. And it is a dissociative medicine. So we know that part of its effect comes from people essentially being able to leave their bodies in a way where they don't feel pain, whether it be emotional pain or physical pain, the way they might. So esketamine is, if I'm a chemist as far as my college degree, so I remember enantiomers, and I don't expect anyone to know that, but just to know that you can essentially take a drug that's well known, and then because it's a mixture of two different enantiomers, you can then create a drug and patent it just by simply saying, well, this one only has the S enantiomer, so now we can have a patent on it. And that's essentially what's happened with esketamine. It's the enantiomer isolated, and it's a nasal spray. So it's been used for treatment-resistant depression, major depression with suicidality. And that, I think that's really great at the level that even though ketamine doesn't have those FDA approvals, we can essentially assume that it will have the same benefits though. And that's what we found. What I didn't know about this as I dived into it more, I knew it was expensive, and I've heard it's not as predictable because it relies on someone, say like me, who gets a lot of allergy symptoms and nasal congestion, and then maybe someone who has really clear airways. they're going to have different levels of absorption of that medicine sometimes, or their technique of using it. So that's one of the, I guess, the opinions that's a negative opinion of why some people don't consider it as good as other options. I've also read that, and I didn't know this before, is that it's meant to be taken with an oral antidepressant. And I have no idea where that came from, but maybe that was just something like, well, we don't want to take market share away from drugs like pills, so maybe we do it as a combination. I have no idea, but I just found that kind of fascinating when, in my mind, it would be like, how do we get people off their oral antidepressants? So the cost, I knew it was a lot, but when I looked into it even more, I was kind of mind blown when I saw how much it costs. So just someone starting the medicine, $5,000 to $7,000 the first month, and then up to $50,000 a year. So, if you only do it for a year and you're cured, maybe that's worth it in some cases, but I think it's just an unknown. If people continue to need ketamine for a lifetime, the cost of esketamine compared to ketamine could be, such a massive amount. So ketamine, I'll just go over this briefly, assuming that some of you may know this, but most commonly, I'd say in an outpatient setting, because a lot of therapists can be using this too if they have a prescriber, is just putting it in the mouth, having it under the tongue, swishing. So it can be a lozenge, it can be a liquid, it can be a troche, but essentially you're absorbing it through the mucosa of the mouth. And anywhere between, I think, 12 minutes, 20 minutes, that medicine is held in the mouth. So a little bit cumbersome because you build up saliva, but it's quite easy. If people swallow it, then there's also oral absorption. And that gets labeled sort of being the tail. So people can have more immediate onset through the mouth and then have a delayed onset through what's absorbed in the gut. And that can create some good things, but also some bad things in a clinical setting in terms of how long it lasts. Intramuscular, just like a vaccine, would be usually in the deltoid or in the thigh or the buttock area. Intravenous, so an IV, and then subcutaneous is emerging. But what I find interesting about the first three, just because I've not been exposed as much to subcutaneous yet, is that they do all have their purpose. So some people allow patients to be using it at home, whether it's supervised or not. And that obviously, the oral option can be very helpful in that case. The intravenous, the most challenging, because you need an IV placed, is similar to the sublingual in that they tend to be more they're gentler. And the intramuscular gets labeled more like the atomic cannon, rapid onset, very strong. And I've heard some of my mentors describe sublingual and intravenous as more of like a receptive experience or feminine experience if you're going to identify in certain ways, but intramuscular being more aggressive. And like I said, that metaphor of an atomic cannon where you're sort of blasted into the ethers with, if it's a high enough dose, psychedelic effects. It's a very different experience, and that might not be ideal for people if you don't know what they can tolerate, if they've had prior trauma, dissociative events already. So any questions that have come up yet, Stephanie? Okay. And the ketamine mechanism, even as a chemistry major, is so complicated. I was just like, I'm not even going to try and summarize that. So at least not in this talk, but there are multiple layers of why it can be a psychedelic. And it essentially comes down to the NMDA receptor. And so whether we're talking about Parkinson's disease or something else that relates to the NMDA receptor, ketamine also has a role there in terms of how it works as a NMDA receptor antagonist. What's also quite interesting to me is that we really don't know why it's an antidepressant. despite all of the use. We don't exactly know why. We can just say, yes, ketamine is an antidepressant for this reason. We can hypothesize, but we're not exactly sure. And then
Arlene asked, does it only work while it's in the system, or does it last longer?
well, this gets at the idea of neuroplasticity. So let's say that if the whole point, and in my mind, this is where I am not as fond of Western medicine, is that if we take a pill that only works while we take the pill, it doesn't do anything to help reverse or cure a condition. So the idea of ketamine or any psychedelic is that it changes the brain, that our brains are plastic, neuroplasticity is the term. And the idea is that we use it and it has immediate impact in terms of our experience. But if it's caused changes in our neurons and the pathways in our brain, the effect can be sustained or maybe maintained forever would be the hope. So it's not always clear, like it's not usually going to be use it once and you're cured, but the cumulative effect of using ketamine and or other psychedelics is that we can get at the root of maybe what's causing our distress. So one area of controversy and or study is that dissociation. For a while, there's been a push to see if we can get the benefit of a psychedelic without having people need to have a psychedelic experience. And that, in theory, could still be of value, right? If the psychedelic experience has nothing to do with the healing. But in my mind, and a lot of my mentors or colleagues think that the dissociation and or the psychedelic experience is actually part of the antidepressant effect. And it could be both. Both may be true. So if you do a low enough dose and you don't dissociate, you don't have a psychedelic experience, we do see there's still some potential benefit. But if you also have people fully dissociate and have a psychedelic experience, and they also get that benefit, in my mind, it's just trying to figure out, like maybe it's a yes and we just have to learn more and more which type of path, one being psycholytic, meaning you give a low enough dose that it helps just take down people's rigidity, but still allows healing, versus a higher dose that's psychedelic. You can have two different experiences that might serve two different clients in a very personal way, and ultimately just help them down the same path. So I think we're going to find out more and more as the years go on, where is the value happening? And in my mind, it's probably just a spectrum and what our end goals are. Just going to do a quick time check for myself. Okay. So the ketamine wave is kind of what I just came up with. It was just trying to figure out, all right, what are we experiencing right now? And I don't know. I've seen enough boring published journal article titles or other presentation titles. I just tried to come up with some metaphor to think about like what we're experiencing right now. And in Denver specifically, I've been here over 20 years now. And then my parents were here, 25-ish years ago, and I grew up in Colorado Springs. So I've just seen how when cannabis came forward and people talked about how there's more dispensaries than Starbucks. And I think that's still probably true. While I don't see people putting up a shingle on the street that says ketamine, I think just in terms of people who are therapists or psychiatrists, otherwise, that ketamine is happening a lot right now. A lot of people have easy access to it, whether it's a storefront that has clinics in Denver and in Austin, Texas, and throughout the country, or it's set up to be more a model that people can sign up, they get a telehealth appointment, and then they ship ketamine to their home. It's very easy to access right now. So that's my idea of, we're clearly in a wave right now, and how big that wave will get and will it ever come crashing down, I think is part of my question. The program I alluded to about people being able to sign up, get a telehealth appointment, have ketamine shipped to their home, there's some controversy there, is that people are receiving really high doses for their very first experience. And while they might be supervised on a video, I think it's also possible they might not. They might take it on their own. And so there's a little bit of uncertainty, like what could happen. And I always tend to go to worst case scenario in terms of what happened 50, 60 years ago. Like, could some adverse events derail some of our positive progress around legalization of psychedelics? And while I couldn't confirm this, one of my colleagues said that he's heard that you can even be taught how to give yourself an intramuscular injection with ketamine through sort of like a mail order telehealth type of situation. So that, I think is just fascinating, as far as how easy we can access this.
Does that change the price or make it more affordable?
Yes, and that's one of the benefits of these models, is that ketamine is expensive. There's no doubt about it. Even when we're talking about a drug that's not expensive by itself, the layers that we add, if we need to have a doctor or a nurse or nurse practitioner who can inject it or start an IV, and then models where we actually sit with the patient or client for up to 2 hours. So a therapist, doctor, other medical provider, that's very costly to have those models. And so some models will put people in rooms by themselves with video cameras, so they're still monitored, to help bring down the cost, increase the access. And I fully want ketamine to be accessible. And I think we're just in that area right now where we're not sure how do we do this in a way that it's accessible, it's affordable, and it's also safe. And so I'm hoping, because ketamine is such a safe medication in most cases, we don't have these adverse outcomes. But if I talk to my malpractice carrier for a minute, then I start to have all these fears of like, oh no, and some of it's very personal. Like, what if I ever had a bad event and I got sued? But I think as an industry, we just have to be aware of what might harm someone and what might totally derail this momentum we have right now. The other piece of the wave that I see is just how many trainings are available. I did mine about a year ago, and I think that group does one every 2 or 3 months. That's putting out maybe 100, 150 trained people a year. But then I know of other ones that are seemingly much bigger too. And then I hear a lot about other trainings that are happening that I don't have as much knowledge. But I think the idea that therapists, medical providers, nurses, people who come from other healing professions that can also do this work with a prescriber and or just as part of an integration team, it's clear that there's a lot of opportunities to get trained. I did a yoga teacher training many years ago, and at one point I just thought about the fact that so many yoga teachers were being trained, but yet there weren't enough positions to actually give them opportunity to teach afterwards. So then that's where I just want to think about, like, what is the cost of investment for people if ultimately they might not even be able to provide this service the same way? And I'll speak to that in a minute. So the other side of trainings is that there's just so many offerings out there. There's not a clear accepted standard right now on what's considered acceptable training. Okay. So other aspects of the possible crash is what I just mentioned before, that it does require a prescription. So someone with a prescribing license is going to have to be involved for legal ketamine use. And I don't know if there is or if there ever will be a prescriber shortage. I just think from a personal point of view that, one, there's a competitive element, that if I'm prescribing for someone else, they may, even if I like them and like working with them and as a colleague, in a way I'm creating more and more competition for anyone I work with. And why I've been a little bit hesitant to just actively say, yeah, I'll prescribe for your clients, is the liability piece. And that's where I just worry about, I meet someone once, I do an intake, I write them a prescription, and then I may never see that person ever again. And they're getting their care with someone else. They might be using it at home inappropriately. And that's where I think there might be some conflict at some point with how many prescribers want to be writing outside of their own clinic. And that's also come from my own malpractice carrier. When I was talking to them about this, when I even mentioned the idea of home ketamine, they were just like, no home ketamine. So I think there's just a lot of fear right now as to what can happen if someone's not properly supervised. And one colleague shared the other day is there might be a point in time where anyone who's using ketamine might have to work under the same roof as, say, like a clinic where the prescriber is located and they're working in collaboration and not necessarily these complicated networks of just collegial type of relations. The related to this is that the same colleague just said, if I'm still medically liable the same way, whether that client is with another medical professional or healthcare professional, that is a pretty big risk, because I'm not controlling that other person in any way. And I say control, just meaning like, I don't know how they use ketamine in their office. Do they allow people to use it at home? Do they sit with them the whole session? Do they let them leave their office without seeing their driver show up to drive them home? Because some people will try to escape some of the rules around no driving after a session, and that could be extremely dangerous. So that's, I think, just where, as a prescriber, I get concerned. I'll say one thing about, we have a large number of trainees, and everyone's going to have a varying ability to hold space for another client. I think that's just human nature. And if you've read the press at all in the last year, it doesn't even need to be someone obscure. It could be someone very well known in this industry who gets brought to people's attention about alleged abuse of clients while they're under the influence of ketamine or psychedelics. And so just imagine someone without a high profile, there is a chance for people to potentially, be obscure, under people's radar, and not doing good services for their clients when they're in a very dangerous and vulnerable state. So with the idea that MDMA and psilocybin will probably be legal as long as nothing derails our progress in the next 1 to 3 to 5 years, I think the fact that we're now bringing in these other scheduled drugs, that are Schedule 1, I think both of them are considered Schedule 1 right now. But the idea that those might be considered more dangerous drugs, I'm just imagining that there might be a higher level of oversight of all psychedelics, including ketamine, when MDMA and psilocybin get legalized. So how I just imagine that maybe me, myself, and others can avoid this crash if it happens, where there's so much personal interest, so much professional interest, and then we're not exactly sure where this leads. I would just say to anyone, like, if you're passionate about the work, do the work. But there is a fairly high cost to be trained. There's a fairly high cost to the networking piece, the finding a prescriber, the setting up of a clinic, and the hoops that I have to jump through just to get a controlled substance, even in my office, is massive. And I'm a small clinic. So just knowing all that is out there, that's where I just encourage people to follow their hearts if this work really calls them, as opposed to just saying, well, I just need to be trained in ketamine because my clients want it. And sometimes it might just be saying, well, I'm not going to do it, but I have these other colleagues who do. And that might be a way to just save a lot of time and financial investment in something, unless you're really passionate about it. And then otherwise, just naturally, I tend to be someone who wants to do something that's not being done or that's not as common. And that can make my life really hard sometimes, that I get bored with the easy stuff. But I think the idea of just, if you're going to offer ketamine, do it in a way that's unique to you, or in a way that it's just adding to the offerings, and not just another infusion center or another ketamine center. Because I don't know, I'm not going to compete with venture capital and someone who probably has $100,000 a month overhead in multiple cities throughout the country. That's not my interest. But I also don't want to create a model that's so similar to that one, where why would someone want to come to me and pay a lot more when it's not any different? So that's where I just try to set myself apart and let people know it's going to be very personal, and it's going to be time intensive, and I won't ever leave you in a room by yourself. And I don't try to highlight this, but it was part of some of the psychedelic protocols, is that I have a defibrillator in my office. It's just things like that I think some people might not go the extra yard to make sure that if something goes wrong, that it's something that can be dealt with very easily and safely. And then the other piece about avoiding the crash, some of the psychedelics I didn't mention, ayahuasca, peyote. What I worry a lot about is that whether they're legal or not, is that we start appropriating indigenous medicines or basically endangering plants and animals that, in my mind, are the medicines of indigenous peoples. And so I think as much as we start to legalize certain medicines, a lot of indigenous people believe that certain ones shouldn't be made legal, like peyote. And maybe that will help decrease the risk of something becoming extinct, like a plant or an animal. And I tend to be on board with that, is that if I'm going to use ketamine, I can do that in a way that I know this is a Western medicine created in a chemistry lab, and that I'm not, taking something from an indigenous culture that might have been using it for 12,000 years.
Arlene asked, you say that you sit with a client. Do they talk, or do they just go into their world? Or are you just observing or actually interacting with them?
So I mentioned the psycholytic versus the psychedelic dosing. So psycholytic being a much lower dose, psychedelic being a much higher dose. And I've joked that for ketamine assisted psychotherapy, there's really not much therapy happening if they get a psychedelic dose. Now, if someone gets a psycholytic dose, they could be talking throughout and having, usually a lightly psychedelic experience or a little bit out of their body, but they're still in the room. They know where they are, they can communicate. And so the difference with a psychedelic dose is you usually have to wait for the experience to be mostly over in order for that person to be able to articulate what they want. So other areas that I'm just pushing as far as, and these are things that I've thought about, and I hope people have many other ideas, is just being different. So for me, and this is not my idea, but a lot of people in this arena, and the fact that I've already done a lot of groups, it makes sense, is that groups can lower the cost. And whether that's doing groups for preparatory sessions or groups for integration sessions, I think that's super easy. Now, if you use a group for the ketamine experience, that adds in a whole nother layer of complexity, but it has been done successfully. For example, the Wholeness Clinic in Fort Collins, they've done a study with basically first responders for COVID, and it was hugely powerful. And I think that just shows how so much healing can occur in a group setting. And if you add in a drug that is known to be healing, then it's even more of a synergistic healing effect. So I do think this, and then these are my colleagues and mentors, but saying that the future of psychedelic medicine may be how we do it in groups and how we make it more accessible, more affordable, and the effects more profound, and that we can maintain them longer because we're creating support groups and support networks at the same time we're having healing occur. So one thing that I've talked to a couple of colleagues about is the idea of doing groups for therapists. And this is something we're hoping to pilot this summer. But just the fact that so many therapists want to be using these medicines, and maybe they haven't done a training, or maybe they have, but they just haven't had experience to use the medicine in a personal way. And I just believe that we're better healers if we know the medicine that we're actually prescribing or offering. And so this could be another way just to also give our healers not only the opportunity to heal, but because we all have our own personal things we might have unresolved, but then also have more experience in how do we really understand what clients might go through and how can we help them the best. So the other things that just personally interest me are combining therapies. The fact that we're doing neurofeedback, and one of my colleagues, he told me that neurofeedback, if it follows psychedelic therapy the next day, can be very powerful. And maybe that helps cement some of that neuroplasticity that we're getting, not only with ketamine, but also with neurofeedback when we combine them. And then the sound therapies that I mentioned before, partly just because music is such a guide in my own life and how I use it with ketamine, there could be not just that music heals, but maybe certain types of music or filtered music where we actually change frequencies or take away frequencies. Could we have even more of a profound effect? And then just the way I've practiced pretty much my whole life, personally, but now medically, is that changing people's lifestyle, changing people, how they eat, how they live. Supplements can be very helpful. What if we're making sure that everyone has at least some baseline infrastructure to then allow for some scaffolding on top of that, which might be medications that they take daily. It might be ketamine or other psychedelics that we're also trying to support people beyond just come in and have a ketamine session, that I would be helping them holistically too. And if it's that they're having relationship issues, maybe someday I'm offering couples counseling with ketamine or something like that. But I think there are many ways we can try to just support people that are going to work together. So music, I've said maybe all of this already, but I think this is just when I did a lot of yoga. I could always tell teachers who just played background music and had like a cool sounding playlist for their class, and then the teachers who used the music sort of to guide their classes. And I was always one, when I taught briefly, that I would create the music first, and then I would create a class around that. Because I do see that music can really help people. And I think in an altered session or an altered state of mind in a ketamine session, it can create the mindset that's required for the client. And it also adds to the setting that we're giving to the clients. And for me, that's a curated playlist. And until I get too busy, I ask people what their top genres or top music that they might choose to listen to themselves. So I'm conscious of the music that I'm giving to their ketamine session as far as what would resonate and not just be totally contradictory to what they might listen to and just hate the music the whole session. And other people just believe that lack of familiarity is best. Like, I don't want to put someone under the influence of ketamine and then play a bunch of songs that have emotional triggers for them, good or bad. I don't think that's helping us change the brain. It's just helping us go back into story or memory. And if you look at data around music that heals, there are studies that show listening to this type of music can decrease depression or anxiety. So we do know that music can heal, whether it's filtered music or just a certain genre of music. And some of the sound therapies that I've experienced too is that movement is meant to integrate with the music as part of the rewiring of the brain, like cross-body movements to help our brain learn and change behaviors. So this is where I just get really fascinated. You can't do that as much with psychedelics, especially ketamine, where people might not even be able to walk. but I think the idea is just that there's a lot more to this story when we start to look at how music can heal and might add to the healing that psychedelics provide.
We have a comment from Matthew Phillips. He said, I'm an LCSW and board certified music therapist. I completely agree. Are you familiar with the Bonnie method of guided imagery and music? It has its early roots in LSD research. It uses recorded classical and orchestral music.
Yeah, what was the first word? Did you say
Bonnie, B-O-N-N-Y?
Okay. I am not, and I would love to know more though, Matthew. So if you care to reach out, I'll have some contact on the last slide too, because I do think there's a lot of excitement in this arena and opportunities for the future.
The other question that came up was what other types of conditions that ketamine might work with, specifically does it work with schizophrenia?
Yeah. Well, depending on who you talk to, I think we have some definite areas that we try to steer clear from. And sometimes those are just simple medical issues, like someone who might have cardiovascular disease. And even though we believe it to be safe, we might be reluctant to just aggressively use ketamine. When we get more into the mental health arena, where we tend to steer clear from often are personality disorders, things that involve dissociation, because someone who already dissociates and maybe not in a healthy way, then we give them a medicine that in a way forces them to dissociate. It just opens up I think the possibility of having, what might get termed like a bad trip or a bad experience. And people with severe trauma, while these medicines, I think, especially like MDMA and psilocybin, the studies coming out in veterans, can be very helpful. If people have severe trauma they've not yet resolved, we do have to be really careful. So we might start at a lower dose. Now, with something like schizophrenia, where we know a schizophrenic will hallucinate at various levels, some of these initial medications, in a way, they cause someone to feel schizophrenic, right? We hallucinate, we might do things that might not be in our best interest. So I guess for me, it's this spectrum of, could we use it for schizophrenia? I would say definitely yes. Do we need to tread cautiously? Again, I would just say absolutely. And it's interesting that as much as I've read about it, I've not seen anywhere that it says contraindication schizophrenia. I've not seen that. But I do think because of the severity of the illness, we would just want to be really conscious about how we approached a patient that already is struggling. And now we're going to give them something that might accentuate some of the things that are already going on in their life. So I wish I had a better answer. And I think I have one of my colleagues join. I don't know if he's still on, but when we get to questions, maybe he can even chime in. He's probably had a patient with schizophrenia and he could just tell me or tell us if he's ever use ketamine with those clients.
So, Brent, I just want to bring your attention to the time real quick. Yeah. We do technically we're scheduled till 1:30, so we have plenty of time, but
okay.
Yes, need to be your timekeeper. So I just wanted to show you.
Yeah, thank you. And we're about done, and certainly people stay on if you like. The idea of just spirit and psychedelics, there's some controversy in the field where some like devout researchers that have been in this field for a long time, like they hate the term entheogen, the idea that you have a chemical substance, typically a plant that you ingest for the purpose of bringing on like a spiritual or religious experience. You know, and I think for me, I'm just not dogmatic about much of anything. So I'm less concerned about the name, but some people really want that spiritual experience. And so in my mind, it's like, well, if a psychedelic gives someone access to spirit and they want to see it as an entheogen, it's like, yeah, great. Some of the issue might come into prescribing because right now it's off label. In theory, I could do it for anything, but if I ever got brought before the board of medicine and I just said, yeah, I gave this to 100 people because they wanted to explore spirituality, you know, my peers might not see that that's a valid reason. But in my mind, there's so many other diagnoses, whether they just be adjustment challenges or anxiety, that we can still approach personal growth and spiritual exploration, I think, in a way that still fits a medical model where we might still need to attach a diagnosis to people. And again, I come back to the idea of I want to be a conscious user of these medicines and that I'm not infringing upon, you know, any indigenous traditions, cultures, plants, animals, unless I have permission and or proper training. But in the end, I just feel like that's going to be best done by people who were already trained in that for thousands of years and not just someone who goes to Peru for a month and comes back to the US and starts offering ayahuasca weekends.
Jennifer Peterson asked, psychedelics have been shown to help with addictions. Do you have any data that shows how it may support other addictive components like food or technology?
Yeah, I don't around, well, I say that I haven't seen the study, but I do know that I've seen that ketamine has some success with eating disorders. And when it comes to technology, I just think anything that shows up as addiction, and we all have our own addictions, whether we have a stigmatized one. But one of my first slides where I talked about LSD in a high dose prevented alcohol use in almost half of the people after a year. I mean, that's hugely powerful. So what if our endpoint had been emotional eating? Or what if our endpoint had been online porn addiction? It was just, that study was done so long ago, we probably weren't thinking about it the same way, but I'd be very curious to see if it could have the same power. And I bet it would. It just might look differently and we might have to study it differently. So I'll end here pretty much, but just to say that, you know, in my opinion, ketamine is very safe, very powerful. It can have rapid, meaning even 40 minutes. An IV can take someone from being actively suicidal to suicide is not on the table anymore. And that's in 40 minutes. You know, compare that to a 72-hour hold and the trauma that can produce in someone if they're suicidal. And then we send them home and they're not any better. You know, we didn't give them anything. So I think that's where ketamine is underused. I think for anyone undergoing surgery with a mental health issue, ketamine should be part of the surgical protocol, you know, just to give them a little bit of a benefit. And likewise, I think anyone that comes into the emergency room with suicidality protocols, they all get an IV of ketamine just immediately and then reevaluate them. You know, simple things like that would be very cost effective and we could see that it's working very quickly. So yes, ketamine, all the psychedelics, lots of excitement, and I think some reasonable risk that we just want to be conscious of, you know, whether we're taking it, whether we want to offer it, whether we have clients that we know are using it, whether or not we're directly a part of that. So just a quick plug, I've realized now, having worked for myself for a long time, that it's hard to grow, but I'm also one human. I can't sometimes reach the people I want to reach without others. And we are actively looking for a neurofeedback therapist because our senior one is moving out of country. And then we're just, over time, we are looking for creating the IV option in our clinic, not just for ketamine, but for other therapies. And yeah, it's expensive, period. But if I'm having to provide these modalities, it's even more expensive as a physician. And that's where I like the idea of working with other professionals so that we don't have to charge as much when we're paying for a psychiatrist or a physician to be in the room. It's much different than if we can pay, say, a registered nurse or someone who's trained in ketamine use, but we don't have as much liability sometimes or overhead for other professions. These are the few references that I accessed. And I'm happy, I don't know how these things get shared, but if something comes up and you just want to know what reference I used or a slide, I'm happy to figure out how to share some of this information. So yeah, thank you all for attending. This is a direct email that right now I'm the only one answering. So it's more or less my personal email for the Heartmind Medicine Clinic. So you can also go through the website just to submit through the form if you want to reach out to me. But I'll stick around for as long as Stephanie keeps this meeting open and answer questions, or people feel free to unmute yourself and chime in. David Nickel, Dr. Nickel, if you're still there, you could tell us if you've ever treated someone with schizophrenia and ketamine, or if you have an opinion, but I'd like to hear from anyone else, whatever your thoughts are. Thank you.
Well, how would somebody refer a client if they are suspicious that a current client they have might benefit from ketamine? How would a therapist go about getting them connected?
Connected with me or connected with just any place that offers?
Both.
Okay. Well, for me, I usually, even my own patients on the primary side, whether it's primary mental health or primary care, I will just give them the Heartmind Medicine website, because I think it gives a good feel of what they might experience with me. And that may resonate, versus they could go to some other place for a lot less money. They might even be able to use their insurance, but they need to know they're going to be put in a room by themselves, and it's going to be a bigger facility. And I don't know if that facility offers integration sessions after the ketamine. So that's where I think people need to understand what they really want and what they're going to get, because that's my biggest concern, is that people have a bad experience just simply because of the setting not being set up to support the person. But feel free to reach out on email. I'd say the best way initially is just to know who I'm talking to, and then we could either talk briefly about the client, or you could refer the client to the website if you wanted them to reach out to me directly.
Hi, Brent. This is David Nickel.
Hey.
This was a wonderful presentation. I learned a lot, and I'm a psychiatrist in the Highlands, and I prescribe ketamine, usually intramuscular, once or twice a week, to patients who are depressed or anxious, and have had good success with it. And I have not prescribed it or given it to anyone with schizophrenia or a psychotic disorder. I don't think it would be helpful. But if someone had schizoaffective disorder and was on medication for schizophrenia and severely depressed, suicidal, and had failed on the addition of antidepressants, then I think an inpatient use of ketamine could bring them out of their depression. But that's something I've had no experience with.
Yeah. Yeah, thank you, David. And just to clarify, if it was Arlene that asked that question, that trained as a family physician, like I know when someone is highly complicated and just someone that I'm going to refer to someone with more experience, whether it's Dr. Nickel or an inpatient setting, because I don't want to neglect those patients because I know they still need help, but I would just honor that I'm not the person that's likely going to take that risk or think that I can help. That's where I think we got into trouble with some people who are very cavalier in their use of psychedelics in the past. And ultimately, I just want someone to have the best chance at healing. So I personally would steer clear of a lot of those gray areas or high risk diagnoses of making things worse, not better. Thanks, David.
Sure.
Hi, Brent. This is Jennifer. I'm in Fort Collins. I have a quick question for you. Can you hear me?
The volume's a little low, but I can hear you. So I might just be leaning into my speaker.
Okay. Oh, I'm sorry. I'll lean into mine.
Okay.
So I've been doing neurofeedback for 13 years. And this feels like kind of the next step in functional mental health and healing. And I really appreciate the points that you've stated in that realm. My question is regarding training, and can you hear me okay?
Yep.
Okay. In my mailbox, I'm getting quite a few certifications or indications of certifications coming in regards to, more of the psilocybin trainings or things along that nature. And they're all over the board of what they offer and what they say needs to be part of the training to be assisted. A therapist as an assistant in a psychedelic, treatment. So I'm just curious what you think, to look for bullet points in these trainings, what you feel would be most important to look at for getting certified, does that make sense?
Yeah. And one thing, like just in your back door, if you're in Fort Collins, I think just going in, if you've never been to the wholeness clinic, just to go, just to read. Yeah. And it's not directly under wholeness, but the Psychedelic Research and Training Institute, PRATI, I think their website is pratigroup.org. That's who I did my training with. So I can only speak to that training that I did. I think every training is going to be a little different in terms of that one. I think is a 4-day training. You get an experiential component. So I think no matter what, unless you have a history of fairly in-depth use of psychedelics, including ketamine, because it is different, you want to just know what your client's going to be experiencing. So I think that experiential piece is very helpful. There's a much larger training group in Boulder. I think there's one in California that they're more like they're not just 4 intensive days. They're spread out or they might be over a whole year. Through MAPS, I've applied to be part of their MDMA training. And that I think is, again, a longer thing, but I don't want to speak to like as if I know, but I think the experiential piece is critical. And just feeling like, is the group, do they seem like an ethical group versus just trying to churn out people and charge them a lot of money and not maybe, because we now have access to an alumni group and people exchange questions all the time. And so it feels like it's not just a weekend training and then you're off on your own. There's still a lot of sharing of information. I got inspired by one of the the people who does a lot of the music, and I recreated one of his playlists, and then I shared it with the group. And so I like that idea that it feels more collaborative. And just, I'd say just that it feels comprehensive. Are they speaking of ethics? Are they speaking of how we steer clear of indigenous cultures and misappropriating or appropriating information? That's what I would want to see, that it just seems like there's a good group of people that are behind it. And that's kind of my nutshell version.
And what was the one that you said that you attended?
I did the Prati, the one. So they're affiliated with Wholeness in Fort Collins. So I think it's pratigroup.org, and they would talk to you about their trainings. And it's not to say that there aren't others that will be good. I just can only speak to that one personally because I did it. And then I have been asked to participate in other trainings, maybe as a doctor that's overseeing other people's experience. But I haven't done that yet. So I can't necessarily speak to all the pros and cons of the different models.
Thank you so much.
Sure. And Jennifer,
Any other
if you
questions? Sorry, Brent.
No, that's fine. I was gonna say, Jennifer, if you have another question, you can always reach out and I'll try and answer more directly. And if I don't know, I won't try to answer it. I'll tell you that, but feel free to ask me anything that's on your mind, or if I didn't speak of something you wanted to hear about. I did want to acknowledge, it's nice to see some names. There's no face, but to see some names from my past on the screen too. So it's great to just have moral support in the background from my past lives and friends and colleagues.
Very good. Well, if nobody else has any questions, we'll begin to wrap up here. You will be getting a follow-up email with the link to the recording if you're interested in rewatching any of what we've talked about today. If you have any needs for office space, you can email support@behuman.ly. And we've included Brent's contact information on the screen here. We thank everyone for being here today. I really appreciate Brent being here and willing to talk to us about all of the interesting facets of ketamine. And again, thank you all for coming.
Yes, thank you all for coming, and feel free to reach out at any point. It's nice to keep building a network.
Awesome.
Yeah, take care.
All right, take care.